Hello and welcome to the Kickoff for SWOG1404. This is an adjuvant trial comparing interferon to pembrolizumab in resected high-risk melanoma. My name is Kenneth Grossman and I'm the study PI, and first of all I would like to thank you for participating in this important trial. During this talk you will hear about the study, including its background, overview, and statistical design, registration steps necessary, data and sample submission, patient-reported outcomes, imaging, quality control, and study monitoring, a brief introduction to the informed consent process, and finally acknowledgements for all the hard work which went into developing this study. The intended audience for this includes anyone conducting the study at a SWOG, ECOG, or NCIC site. Those personnel would include CRAs, data managers, and principal investigators. By way of background, it is notable that stage 3 melanoma carries with it a poor prognosis, with a 5-year overall survival of approximately 50%. Relapse in melanoma can cause morbidity and mortality, with over 50% of melanoma relapses occurring at distant sites. Presently, the only FDA-approved treatments for adjuvant therapy in the U.S. include high-dose interferon and pegylated interferon. Though ipilimumab may receive approval during this time window, it does have notable long-term toxicity which may limit its use. Interferon, or high-dose interferon, has been selected as the control arm of this trial. It is the only treatment to date in melanoma that has shown both an overall survival and relapse-free survival benefit in multiple randomized controlled trials for those with high-risk resected disease. It has well-established management algorithms that define dose reduction and treatment cessation in response to toxicity. We expect for this trial, the community of oncologists conducting it will be well-versed in the management of the drug. If there are further questions about unique toxicity scenarios not easily answered by the protocol, please contact the study chair. The experimental agent that has been selected for this study is called Pembrolizumab. It is a PD-1 inhibitor and has shown exceptional response rates and safety in stage 4 unresected melanoma. Of note, responses were seen in about 30 to 40% of previously treated patients in a pivotal phase 1 study. This data has been demonstrated in subsequent work in the frontline and second-line setting. The adverse event profile is favorable and also has well-defined management algorithms available in the protocol. Objectives of this study include overall survival, which will be assessed for the whole study population as well as the PD-L1 subgroup, and relapse-free survival for the same two subgroups. Toxicity will be assessed as well as quality of life endpoints measured by the FACT-BRM and EQ-5D instruments. Pharmacokinetic and ADA testing will be done on patients receiving pembrolizumab to better understand how this drug performs in the adjuvant population. Finally, tissue banking will be an optional objective which patients may choose to participate in. Of note, for the current correlatives in the S1404 adjuvant trial, 91% of patients have agreed to banking and 81% have actual tissue, so our expectation for tissue collection for this study is high. This study design is a simple 1-to-1 randomized open-label trial comparing pembrolizumab, or MK-3475, dosed at 200 milligrams IV every 3 weeks for 1 year. This is being compared to high-dose interferon delivered at 20 million international units per meter squared per day, IV, days 1 through 5 for 4 weeks, followed by a maintenance phase of 10 million international units per meter squared per day, subcutaneously every other day, 3 times each week, for up to 48 weeks. Entry criteria includes the patient being surgically resected with adequate margins. This is defined in detail in the protocol. AJCC staging will extend down to 3A and 2 disease, with patients eligible all the way up to fully resected M1C disease provided there are no brain mets. To be eligible, patients must be at least 18 years of age, and they must have completely resected melanoma as described on this slide. No prior treatments are allowed. Prohibited prior treatments would include any chemotherapy, vaccine therapy, or other therapy directed towards melanoma. Adjuvant radiation is allowed and must be completed within the day 84 time window of surgery to the first dose of study medication. Patients with HIV disease are allowed and encouraged to participate in the trial, provided they have adequate CD4 counts, which is described in the study documents. Patients must be randomized within 16 weeks of the surgery and must have no autoimmune disorder or hepatitis B or C. Again, no prior immunotherapy is allowed, and the PD-L1 assay must be performed and reported prior to enrollment of the patient on the trial. It is important to note that the PD-L1 results will only be available to the patient and the study team following completion of the trial. This study will require 1,000 240 eligible patients, and we estimate up to 1,378 enrolled to achieve this, as a 10% ineligibility rate is anticipated with the study. There is a 1-to-1 randomization between the two arms with 620 eligible patients per arm. The primary endpoints include overall survival and relapse-free survival. To achieve this, we anticipate 3 years of accrual at 45 to 50 patients per month, this number being estimated from prior adjuvant studies conducted within the cooperative group. Final analysis will be expected within 2 additional years of follow-up. The analysis plan for this study includes 2 interim analyses for overall survival at 55 and 80% of deaths. This is expected to occur at approximately study year 4 and study year 3. The final RFS analysis at 100% of RFS events is expected to be at year 3.5. No interim analysis for RFS or PD-L1 positive subgroups will be performed. For registration of patients, they must enter this study through normal screening procedures, and slides must be submitted for PD-L1 testing. Once PD-L1 testing is complete, sites will receive an email from SWOG that indicates that the testing was done and the patient can be randomized. No PD-L1 information will be relayed to sites or patients. The patients will be registered from randomization within 7 days and subsequently manage treatment.
In this section, we're going to discuss steps you'll need to take before you can register your first patient. Here is a screenshot of. Once you've logged on to the SWOG specimen tracking, enter your contact information on the S14. For SWOG sites, the contact information will be Your initial order will contain 4. The patient must be registered to the screening step of S14. After you've registered to, when you log your tissue specimen into the specimen tracking,
the data and sample submission are well detailed within the protocol, with Section 14 of the protocol containing instructions for data submission and Section 15 containing instructions for sample submission. This includes instructions for PD-L1 testing, tissue banking, PK and ADA sampling, quality of life administration, and image submission to IROC. Patient-reported outcomes will be done throughout the trial as they directly measure the effect of a treatment on the quality of life from the point of view of the patient. Treatment-related toxicities are likely to impact these patient-reported outcomes. For adjuvant therapy, our main goal is to improve survival without any deterioration of quality of life, so the measurement of the patient's perspective is very critical. 2 instruments will be used in the trial, and these include the FACT-BRM, which has been used in other SWOG adjuvant trials, as well as the EQ5D. Details of these documents should be uploaded from the SWOG site. PRO instruments will be administered at baseline, week 4, week 13, and every 12 weeks while in treatment. Following treatment cessation, there will be a 24 and 48-week administration of the instruments. At relapse, the PRO instruments will be administered as well. All participants will have brain and body imaging with PET-CT, standard CT imaging, or MRIs at baseline pre-treatment. They will also have scans done every 12 weeks until 2 years from randomization, and then every 6 months until 5 years from randomization. PET-CTs and/or MR images must be locally read and interpreted by the local site, Radiology Services. For brain imaging, MRI with contrast is the preferred imaging option. If PET-CTs are used, a CT with contrast should be submitted in addition to the FDG PET images. If IV contrast is contraindicated, then a CT scan without contrast of the chest and an abdominal MRI are the preferred imaging modalities for whole body imaging. Imaging exams must also be submitted to the Imaging and Radiation Oncology Core, or IROC, via the Triad system for quality control and image banking purposes. Quality assurance will require mandatory training of key site personnel prior to the first person being registered at the site. In addition, mandatory centralized training will be done if major changes to the protocol occur or common problems are occurring during the monitoring and/or audits of the study. There will be oversight through routine auditing and monitoring using a risk-based approach to monitoring, as is common for all SWOG studies. Quality assurance will also require one full-time SWOG monitor to be dedicated to S1404 for routine monitoring and monthly communication between the monitor and site staff to assess for potential problem areas, provide feedback, and to identify staff turnover issues. Centralized electronic monitoring will also be done through the SWOG Statistical Office, as well as on-site monitoring as needed. Centralized monitoring will involve review of submitted data, verification of critical source documents remotely via collection, and review of pathology, radiology, and applicable lab reports. Analysis of site characteristics with performance metrics will identify sites with poor performance or noncompliance through the SWOG Institutional Performance Reviews, metrics, and other available reports. Finally, sites will be evaluated for their timeliness of serious adverse event reporting, timeliness of data submission, verification of specimen submission, and off-site review of investigational drug accountability and record keeping on a biannual basis. The informed consent process is straightforward, with all patients required to complete informed consent discussion and sign consent with study procedures, which include PD-L1 staining. Patients may opt in to have their tissues banked for future research, and we are hopeful most patients will agree to this. Finally, I would like to acknowledge the hard work of many collaborators on this project. Tony Rebus and Vern Sondak have provided wonderful leadership and mentorship to me during the development of this protocol. Megan Othis and Jim Moon have worked extraordinarily hard on the statistical design and data input methods required for the study. Their work has extended well beyond this in many areas, and their expertise and experience have been invaluable assets at every phase of protocol development. Sapna Patel, my study co-chair, will be the lead investigator for this study's quality of life component. Jamie Barrett will be the clinical research data coordinator for the study. Val Guild has been a steadfast proponent of the study, and her input has always been appreciated by our group staff. John Kirkwood and Aman Tarhini have significantly influenced this study's design, with insights gained from significant experience acquired during the conduct of E1609 and other studies within the Eastern Cooperative Group. Teresa Petrella will be the NCI Canada study chair. Michael Knopp and his team from IROC have built a terrific structure to allow central banking of all imaging data related to this protocol, which will be a first for our melanoma committee. Emmett Schmidt has been a key scientific contributor from Merck in the design and opening of the study, and has helped assure that the study, should it be positive, have all of the necessary components for drug registration in the US and Europe. And finally, our CTEP collaborators, Elad Sharon and Howard Streichler, have been most helpful in assuring success with the design and activation of the study. Most of all, I wish to thank you for your attention to the details of the study and wish you a warm welcome to the S1404 study team.